the case that you need to use plasma medicine, you can do it. In regarding to the pregnancy and the fetal outcome, is what I told before. The pregnancy is not affecting negative in the baby, and the pregnancy is not affecting negative in the MS, and the contrary, the MS is not affecting negative in the pregnancy. So that there is not an increase in spontaneous abortions, there are not an increase in C-section, and the babies are completely healthy. Yeah, there is not a problem. Many years ago, there were some articles from the interferon that they have said that the patients with MS and interferon, they have small babies, that they are small and they have a less weight. We know now that the babies of the MS patients, they are completely normal. They have the same weight, the same weight, the same height, and the same cranial perimeter. Not very far away. So 5 or 6 years ago, there was a short paper in the Multiple Journal saying that the babies from MS patients, they have a low cranial perimeter, but was not right. It's because they were using the wrong measurement. They was using the general measurement for the whole world and not for them. So that is important. The babies are completely the same like the babies from the healthy babies. No, there is no difference. So regarding the delivery, they can deliver so in a natural way, they can have C-section. The gynecologists, they should decide. We don't decide in which way. Gynecologists, they should decide that they can have a natural delivery or they can have a C-section. That's important. Federal anesthesia or general anesthesia is not contraindicated. Every woman can receive an individual decision. We need to speak to the patients, patient's preferences. We need to think about when the patients deliver, what to do lactation or to start the treatment. That is important because for example, patients that they are coming from high activity treatment like TCA20 or natalismab, we need to think about because they are patients that they have a lot of activity, and when we wait until 4 or 5 months without treatment, the patient they will have a relapse. So that we need to consider every patient and we need to treatment to come from moderate efficacy treatments that these patients probably will not have a relapse, that when you are having patients that they have a high activity disease activity, and these patients, you cannot have the patient 6 months without any treatment. And now, one important recommendation for the postpartum, the patients, we need to manage the sleep. We need to do rehabilitative care for the pelvic floor therapy is important because otherwise they will have urinary problems, they will have bladder problems, and MS, the patients with MS, they have bladder problems. And when you have additional problems because of the delivery, it will be very bad. So that is important to do rehabilitation for the patients that they have problems with the pelvic floor. And it's always important that they have some help from the family or from other people. Now, a very fast summary. I will recommend this article is very important because here in this article are all the treatments and how to do in the pregnancy and the lactation. It's very easy to follow because you see everything in columns. That's the treatment, the label, and what's to do. So that's very fast. We know for interferon to stop when the patient is pregnant. For the dimethyl fumarate, it's the same. Teriflunomide is contraindicated to need to stop during furamide with the without and later the patient can become pregnant. Regarding the S1P, all S1Ps are contraindicated. It's really dangerous to have a patient pregnant and with one S1P, later there are malformations, and there are some articles speaking about this, so that when you have an S1P, depending on the S1P, you need to escape and to go to another treatment. You cannot leave the patient without treatment. You need to do a mix with another treatment. Regarding the AIRBs, for clarity, you need to wait 6 months for women and for men. And the alentusimab, you need to wait 4 months before that she wants to become pregnant. Regarding the TCA20, there is some changes that I will say now. For example, pembrolizumab in Europe was 12 months. In USA, there are 6 months. Now, the change is 4 months. That you only need to wait 4 months. The same for rituximab, for patumumab, they are written 6 months, but in the general practice, we don't wait. And the natalizumab is the only one that we keep, in general, we keep natalizumab until the week 32. So we have a lot of experience with that. We have many patients with disability that they were pregnant, and we keep the natalizumab until week 32, 34, and later we stop. We do with extended dose, so every 6 weeks, and there's not a problem. And later we normally we start natalizumab 2 to 4 weeks after the delivery. So, and there's a very interesting, that was something now in the eclipse from the Italy and France, that they say patients that they are with subcutaneous natalizumab, they have more postpartum emergencies than the patient they were having intravenous. Probably would be because of probably will be in the postpartum, probably because it's not postpartum in the subcutaneous and the intravenous. Regarding the ocrelizumab, I wanted to bring this because it's new, at least they will not change in the lactation and in the pregnancy, because they have now they will publish 5,000 patients with the ocrelizumab and ocrelizumab and the pregnancy, and because of this data, they have changed, and in Europe is now 4 months. You can wait. You need to wait 4 months, and the patients with treated with ocrelizumab, they can do lactation. That is important because they are patients with very high activity. So it means a woman can deliver after 2 weeks, and they can the first weeks they cannot receive ocrelizumab because of the cancer. So a patient that they will be lactation, and after the 2 weeks, she can have received ocrelizumab and she can continue with the lactation. The 2 first weeks after the delivery, you cannot give the anti-CD20 because they can run the medical. After 2 weeks, the patients they can start with the anti-CD20 and they can continue with the lactation. That is important for the women, that they can continue with the want to have continue with the lactation and they need anti-CD20. So that is very fast. It's our cohorts. We have now, I think here, more around 180. I have here the results of 142. It's only to show you that we have our patients receive the mean age is 35. So you know it's getting older and older. So, and all our children, all of them, they were healthy. The mean duration of the pregnancy was 39, like in the general population. C-sections in Spain is 25%, in general population 23%, in the MS population, all the pregnancies was live births. And we have only, I think it's 3% malformation, that is the same like in Spain. And one other important thing is weight, height, and area perimeter was like in the Spanish population. So always need to consider your population. Yeah, the Spanish children are not the same like the Swedish children or Finnish children, they are bigger. So that always you need to consider with the population. That was the problem with the multiple sclerosis article, that they have compared the European cranial perimeter with the general perimeter for the whole board. That was the problem. That was the comparison. You always need to take the numbers of your country, yeah, because some countries the people are smaller and the others they are bigger, so that you need always to compare. Only here to show that in our hospital we are doing in this way. We look always that they are stable, the patient, that they have a treatment before the pregnancy, and our relapse rate is only the 7%. We do always an MRI 2 months after the delivery to show if the patients they have new lesions, and in the case that they have new lesions and they have no treatment, we treat the patients. I think it's important because when between the second and the third month, their hormones are very, very low again, and it's the moment that they have new lesions. So to finalize, so I think to have a successful delivery and so that the patients, the MS patients, they can continue to have children. It's important not the harm for the MS, and the patients with MS, they can have a completely normal pregnancy, the same like the general population. Very important is to have a plan. Very important to know when to stop the treatment, and very important to decide when to start again the treatment after the delivery. Thank you very much.
So, any questions? Thank you very much, Nalia, for this very useful presentation. I have the feeling that in the next future, see that you will be ready to be used whatever situation you're in, right? No, after 2 months, just after one day or even during the pregnancy. What do you think?
So our experience, I am in the advisory committee of the steering committee of the pregnancy in the anti-20s. So that we've seen with the Relisumab, we will now publish 5,000 pregnancies. We will see Relisumab in the first 3